Now, ventricular tachy. Sustained ventricular tachycardia requires immediate intervention. Why? You're worried about VFib. And once VFib kicks in, you're playing with death there, and you don't want to do that. If it's hypotension, no pulse, stop there. Why no pulse? If it's ventricular tachy, you do not have effective cardiac output, right? If you don't have effective cardiac output, because what have you done to the diastolic interval? Whoop. Think about that. Don't you want just enough diastole so that your left ventricle fills up with blood and you have ventricular tachy real quick, right? So therefore, how in the world can you possibly fill that up with blood? Fill it up with blood. You can't. It's moving too quick. So there's no cardiac output. What happens to pulse? It decreases. So what's your next step in management? Cardiovert. What does that mean? It means that you're trying to slow things down so that you reestablish the time that's necessary to fill up your heart with blood to restore that hemodynamic instability. If asymptomatic, pay attention here now. Amiodarone, huge drug for you. It's been making a comeback for years now. And amiodarone, technically, okay, fine. People say that it's part of class 3 antiarrhythmics, right? And class 3 to you should mean potassium channel blocker, but could it have sodium channel type of activity? Could it have beta blocker type of activity? Could it have calcium channel blocking activity? Sure it can. So amiodarone is one of those drugs that kind of has all activities, universal. But you can use it to cardiovert medically. Lidocaine is 1B, but failure to convert may then require sedation and cardioversion. So there are times when you can use medical cardioversion, which I would pay attention to which drugs, and then at some point you must resort to sedation, electrical cardioversion. It's important that you make sure that you're able to properly sustain heart rate in a regular fashion. Okay, to differentiate between SVT and VT, beyond the scope to a certain extent, but I will still keep this in mind. Remember, up until now, we've done SVTs, and we looked at 4 major ones. Know those 4 well. AFib, atrial fibrillation, multifocal atrial tachycardia, and WPW, okay? Know those 4 well, at least. And then you have VT. But what are some of the clues that you want to pay attention to? P waves are clearly present preceding each QRS narrow complex. So this would then favor what? SVT, supraventricular tachycardia. For example, think of atrial fibrillation, atrial flutter, huh? Those P waves were clearly distinct to a certain extent, but the QRS complex was definitely there as being a narrow complex. And by distinct, we don't necessarily mean it looked like normal sinus. The fact that maybe it was wave-like, maybe it was sawtooth, or maybe it was 3 distinct P waves like we found with multifocal atrial tachycardia. If the patient has CAD stands for coronary arterial disease, ICMP stands for ischemic cardiomyopathy, then it's likely ventricular tachy. Is that clear? So diseases in which the blood vessels have been affected, more likely to be VT. Keep that in mind. Most wide complex tachy will be VT. Most narrow complex VT, so WCT stands for wide complex tachycardia, and for board purposes, make sure you know that they most likely will be ventricular tachycardias. If the QRS complexes are narrowed, think of it as being the P waves pushing the Q waves together in a narrow complex, and they most likely will be SVTs. Simple clues that will help you out tremendously, and you don't want to just sit there wasting precious time. And more importantly, feeling frustrated. AV dissociation, we talked about this, where the P wave has no correlation with the QRS complex. Independent. Favors ventricular tachy.